Hi, I'm Monica Embers. I'm an associate professor at Tulane University, and this is a CME for Invisible International and their education initiative, which is funded by the Monte Calvo Family Foundation. I'm going to be speaking to you in this CME about combination antibiotic therapy for treatment of Lyme disease. The objectives for this session are to distinguish antibiotic tolerance from resistance, to examine evidence of persistence via tolerance by the Lyme disease spirochete, Burgdorferi accentuato, to describe antibiotic efficacy studies in animal models and their outcomes using combination therapy versus monotherapy, to appraise the studies that have been done in humans, both clinical trials and observational studies, and finally, to review the conclusions and future directions. I don't have any financial arrangements or affiliations that need to be disclosed relevant to this talk. So to begin, I'd like to talk about what is known as post-treatment Lyme disease. And many patients are successfully treated by timely antibiotic therapy, meaning early antibiotic therapy, but it's accepted that a sizable number of patients remain ill after treatment, especially if that treatment is prolonged. So in this study, it was shown that the prevalence of patients in the United States with post-treatment Lyme disease was estimated to be over 2 million in 2020. So that's probably grown by now. And so this is a significant problem. In terms of the case definitions for post-treatment Lyme disease, the laboratory of Dr. John Alcott has been working on this for a number of years and has developed these definitions for research of post-treatment Lyme disease or post-treatment Lyme disease syndrome. And what's important to take from these studies is that the pattern of symptoms seems to be very different from that seen in fibromyalgia, depression, and chronic fatigue syndrome. So most patients with Lyme disease have lingering fatigue, musculoskeletal pain, and neurocognitive difficulties that can last for years despite antibiotic treatment. Some of the potential causes for post-treatment Lyme disease include the induction of inflammatory responses by lingering dead Burgdorferi spirochetes or their antigens. Secondly, the continuation of active infection. And finally, irreversible sequelae from a previous active infection or so-called autoimmune etiology. Now, all of these can happen in concert, especially item number 1 and item number 3, because the inflammatory response can be autoimmune. In terms of considerations regarding antibiotic efficacy, it's important to realize that the primary standard of care for Lyme disease treatment is doxycycline. And this is a microbiostatic antibiotic. Its efficacy relies on subsequent immune clearance of static bacteria. Burgdorferi is known to evade the immune response in many different ways, so persistence is the norm in immunocompetent hosts. Also, the dormant bacteria, which we know persisters are dormant, are more tolerant of microbiostatic antibiotic, and we'll talk about resistance versus tolerance. Burgdorferi survives for many months inside ticks without nutrient replenishment or replication. So dormancy is part of their natural life cycle. Also, Burgdorferi can be found deep in connective tissues and joints, so it's important to consider how well the antibiotic penetrates different tissues. In terms of the treatment guidelines, the Infectious Disease Society of America recommends that for early or early disseminated phase patients that do not have neurological involvement, they should be treated with either a 10-day course of doxycycline or a 14-day course of amoxicillin, which is reserved for young children and pregnant women, or cefuroxime rather than long-term treatment courses. Patients with disseminated disease, doxycycline or amoxicillin at the same doses is recommended for 28 days. And if patients have clinically evident neurological involvement, then intravenous ceftriaxone is warranted. In contrast, The International Lyme and Associated Diseases guidelines recommend 4 to 6 weeks of doxycycline, amoxicillin, or cefuroxime. And they also suggest that patients with persistent symptoms and signs of Lyme disease should be evaluated for other causes, but if it's judged to be a possible cause of ongoing manifestations, then retreatment is warranted. So, in terms of antibiotic efficacy, we've done some studies in Borrelia burgdorferi with Persister cells, and this has been done mostly in vitro. And Lyme disease is most commonly treated with microbiostatic antibiotics, such as doxycycline. And what we know is that all determinations of the minimum inhibitory concentration, that is what needs to be achieved in the serum for efficacy in humans, have all been done in vitro. So we know that the Borrelia burgdorferi phenotype and the growth of the bacteria changes dramatically when they're inside the host. So it's kind of a black box of what the minimum inhibitory concentration actually is inside the host for these antibiotics. So we've shown that the spirochetes can persist following a doxycycline treatment administered after disseminated infection in non-human primates. We know that there are no apparent mechanisms of resistance, and we know that antibiotic tolerance is achieved by slowed growth. Post-adaptation does contribute to antibiotic tolerance, and the persisters that we observe are considered viable but non-culturable. What does this mean? Well, the viable but non-culturable state is not unique to Borrelia. It's known to occur in over 100 other bacterial species. In fact, the ability of bacteria to enter this dormancy is very common for bacterial pathogens. The VBNC bacteria are still metabolically active and viable, and with the right growth conditions, they can be resuscitated. It's also often associated with morphological changes, and we see this with Borrelia burgdorferi as well, where they sometimes obtain these sort of round body forms. And we don't really know what those round body forms are in terms of their ability to be resuscitated, but this is an area of study that needs to be pursued. So in terms of the VBNC state, there are certainly precedents in other species. There's broad phylogenetic distribution. There are common characteristics, but differences in the induction of the VBNC state and conditions required for resuscitation do vary. Some remain infectious after regrowth, and some do not. The Vibrio species have been most well studied in this genre. So, in terms of the VBNC state of Borrelia, this has been observed in mice and primates after antibiotic treatment. We know that the spirochetes are transcriptionally active and intact, and there's the limited ability to reculture them from humans and non-human primates. I think one of the most poignant studies to demonstrate the ability of these persisters to regrow is this study by Amir Hadzik and Stephen Barthold's group entitled Resurgence of Persisting Non-Cultivable Borrelia Following Antibiotic Treatment in Mice. So the mouse is the environment for regrowth, and the duration from the removal of stressor can also be extensive. So there's a window of resuscitation, which is highly variable between species. So what they did in this study was they treated mice with antibiotics, and then they quantified the levels of bacteria in the mouse tissues over time. And they found that over 8 months post-treatment, there were very, very low levels of bacteria, indicative of antibiotic efficacy. However, when they let the mice go until 12 months after treatment, they were able to identify just as many spirochetes in the tissues as the untreated mice, indicating that they had resurged. In our study in monkeys demonstrated intact organisms in vivo, which were transcriptionally active after doxycycline treatment. So the VBNC state may occur with adaptation in primate hosts as cultivability wanes with prolonged infection, irrespective of treatment. So this is a pictorial display of what to expect with certain bacterial states. As you can see, we start with stationary, and when we go into the growth phase and you treat with a drug, for most bacteria, the drug will interfere with the growth of the bacteria, shown here. And for those that are sensitive, some may grow to different levels before their growth is interrupted. But if you take them and plate them out for colonies, you won't see any growth. However, persisters, when you add the drug, they can form into colonies, and the viable but non-culturable cells may or may not grow into colonies after the drug treatment. And then those that are tolerant of the antibiotic will grow after the drug has been removed, which is shown here because you're taking it out of the liquid culture and putting it onto the plate. So the drug is removed, and you'll see persisters regrow. Whereas when it comes to resistant mutants, the bacteria will grow normally in the presence of the drug. It will not inhibit their growth. So how do we deal with this when we're thinking about how to treat antibiotic-tolerant bacteria? So one strategy is the use of combination therapy. And in terms of the rationale, the idea is that by combining antimicrobials, which utilize different mechanisms to kill the bacteria or inhibit their growth, persisters can be eliminated. This is well established for the treatment of Mycobacterium tuberculosis. So there are a number of different studies shown, in vitro studies shown here, where libraries of different antibiotic compounds were used and were able to kill Borrelia burgdorferi in vitro when used in combination. Much of this work was done by Ying Zhang. And only very few studies have actually demonstrated this in vivo. This is another study of in vitro study looking at combination drugs with cefuroxime, clarithromycin, nitazoxanide, some of the combinations that were used. And you can see that you really only get good clearance when you combine the antibiotics in dual or even better in triple combinations. One strategy that also has been proposed is pulse dosing. But this has shown variable efficacy in vitro and has not been directly tested in animal models. So in terms of the studies of Borrelia burgdorferi persistence, you have to consider the evaluation of chronic disease and the residual pathogen after treatment. And you have to also consider the impact of pretreatment duration on efficacy, which has been studied, and the viability and the phenotype of the persistent spirochetes. One of the first studies done was in dogs who were treated with a 30-day course of amoxicillin or doxycycline 2 months after infection. Spirochetes were recovered in tissues from 3 of the 12 dogs, and skin punch biopsy samples from nearly all the dogs were PCR positive after treatment. And what was interesting was that serum antibodies to Borrelia declined after treatment, but after the dogs were kept in pathogen-free housing, their antibody titers rose again, which indicated recrudescence. In terms of mice, some of the studies have utilized what's called xenodiagnosis, and we've used this in our non-human primate model as well. And this is because sometimes it can be very difficult to detect Borrelia in the tissues post-treatment. So when you feed uninfected ticks on the animals that have been treated, if those ticks are able to acquire the spirochetes, then we know that they persisted. So xenodiagnostic studies have been performed in mice, and 2 studies examined persistent spirochetes as a function of the time elapsed prior to treatment. So this was done by Steve Barthold's group, and they noticed a big difference whether the mice were treated 3 weeks post-infection or 4 months post-infection, whereas those treated early, efficacy was much, much higher than those treated at 4 months post-infection. And then we talked about the resurgence paper by Hodzik et al. In terms of human studies, we don't have a lot to look back on. This is also quite difficult to study because there are only certain specimens that you can take from humans. So in one study, human skin biopsy samples were taken from the erythema migrans and after treatment about 2 months later. And only 1.7% of those were culture positive. And we knew that they were primarily the same strain, so it was not a reinfection. They did not show any change in antibiotic susceptibility, which also indicates tolerance. There's a really nice review here about Borrelia persistence in patients treated with EM. And then finally, there was a human xenodiagnosis trial with patients who had erythema migrans and PTLS patients. And they used larval ticks to feed on these patients, thinking that once the larval ticks molted, if they took up spirochetes, that they could transmit it from the nymphal stage. But working with this, I know that getting DNA from larval ticks is very challenging. And so this was a very difficult study to perform. And from that study, there were 19 negative responses, 2 indeterminate, 1 EM, and 1 PTLDS positive patient. So really, the most reliable means to look at persistence in relevant model would be the non-human primate because they replicate human infection very closely. They are not a reservoir host. They are an incidental host like humans. And we've done 2 studies mimicking early disseminated and late chronic phase treatment. There was evidence of persistence by molecular detection, antigen detection, and xenodiagnosis. And for this initial study, we used a high inoculum. But for subsequent studies, we used tick-mediated infection and again showed that a 28-day course of doxycycline administered 4 months after infection, which replicates the disseminated phase, failed to cure the Borrelia burgdorferi infection. And we saw both inflammation, we saw persistent organisms, and we saw variations in the immune response. There are very few studies which have shown the efficacy of antimicrobial combinations in animals. This study shown here out of Ying Zhang's group showed that daptomycin plus doxycycline plus ceftriaxone was able to eliminate persisters. And this study in mice showed that defotaxime in combination with azlocillin was also able to reduce the levels of Borrelia in mice. But there haven't been very extensive studies using combination antibiotics in mice or in preclinical models. And our lab has performed 2 studies, a total of 17 different antimicrobial agents. The first is a collaboration with Dr. Zhang's group, and the second is a study in mice with repurposed drugs and antibiotics funded by the Bay Area Lyme Foundation, and the first funded by the Stephen Alexander Cohen Foundation. And our goal was to be able to eradicate infection with the Lyme disease spirochete to prevent post-treatment Lyme disease. And ideally, we would like to have a combination therapy that can be administered orally and can be administered over a short period, preferably a 30-day treatment. We also want to be able to use combination antimicrobials to target all forms of Borrelia burgdorferi. And these were tested in vitro prior to being tested in animals. So these are the 2 study designs. There are some differences. For the first study, we had a period of 10 to 11 months to allow for resurgence. We also had a 6-week period, so we measured the efficacy at 2 different time points. In the second study, we waited 2 months after the cessation of antibiotic treatment in order to determine efficacy. But both of them, we waited 2 months before we gave the treatment, which is intended to replicate a delayed treatment period, which is very common for Lyme disease patients. So this is just a sample of some of the results that we got for the first study. And basically what you can see is that cefuroxime, clofazimine, doxycycline, none of these in combination were able to fully eradicate the infection. And we use xenodiagnostic tick culture and necropsy tissue culture. So after 2 months after, 6 weeks after, and 10 to 12 months after, we were able to take the tissues from the mice and determine which drugs were able to prevent the ability to culture. And we have developed a novel culture medium that helps us to regrow the viable but non-culturable spirochetes, which is very important here. So daptomycin was quite effective at reducing the ability of the spirochetes to regrow when used in combination with cefuroxime. We also had cefuroxime, doxycycline, and pyrazinamide, Bactrim, cefuroxime, and doxycycline. These triple combinations were highly effective at eradicating the infection. And these studies are ongoing. We also showed here with multiple different assays. We looked at xenodiagnostic ticks, midgut cultures. We used qPCR to look for DNA in the tissues. We regrew we used qPCR on the tick midgut cultures as well. And you can see here that these are two examples of a combination antibiotics that were able to completely eradicate from detection any of the spirochetes. Cefuroxime, doxycycline, and pyrazinamide, cefuroxime, clofazimine, and doxycycline. So we have a situation here where we've shown, Dr. Zhang showed in vitro that we could clear the infection, we can eradicate the persisters, and now we've shown in vivo that we can eradicate the persisters in mice. The next step would be to determine if we can eradicate the persisters in a primate. And then the study we just published shows that comparison of monotherapy, meaning single antibiotics, to combination antibiotics was very clear. This is the efficacy of the single antibiotics that we tested, which is a number of different antibiotics: azlocillin, Bactrim, disulfiram, carbamycin, dapsone, rifampicin, cefotaxime, loratadine, which is an antihistamine, which has commonly been used for amplifying the response in antibiotic treatment for Lyme disease. Azlocillin is a new drug. Disulfiram has also been used as a candidate therapy. And basically what we found is that none of these drugs on their own were able to eradicate the infection. This shows the culture of tissues. All of these were completely ineffective. And then we did get some significance with cefotaxime in this study, where only one of the 5 mice was culture positive, but all the others were not effective. However, when we combined antimicrobials, we saw a big difference. And multiple combinations were able to statistically significantly reduce the infection, shown by culture of tissues in our BSKH and then our modified BSK, which is our novel culture medium. We've already shown that doxycycline and ceftriaxone on their own are not able to clear the infection. And so what's important to take from this is that the results suggest that combination therapy should be investigated in preclinical studies for treating human Lyme disease. All of these were 30 days or less. So in conclusion, from the animal studies, doxycycline and cefuroxime, among other antibiotics tested in monotherapy, do not clear the established infection. Certain combinations show promise for their ability to eradicate the spirochetes. And again, we need clinical trials. So what about what's been done in humans? So there have been a number of clinical trials using monotherapy. And there have been some differences in the results, but I think we can summarize it fairly effectively. So these are two controlled trials of antibiotic treatment, the so-called Klempner trials, and the patients received either intravenous ceftriaxone, 2 grams daily for 30 days, followed by oral doxycycline, or they received placebo. What's important here is that they had both seronegative and seropositive patients. And then what they found was that in these two trials, treatment with intravenous and oral antibiotics for 90 days did not improve symptoms more than placebo. This was a study, and there are caveats to this. This was a study in the Netherlands where patients received ceftriaxone for 2 weeks, and then they were randomized to oral follow-up treatment with doxycycline, clarithromycin combined with hydroxychloroquine, or placebo. And what they found using the SF-36 scale, which is a measure of physical functioning, role limitations due to physical health problems, pain, in general health perceptions. And they also observed that there were no major significant differences between the groups at either initially or at subsequent study visits. The caveats here are that they had very strict inclusion criteria based on seropositivity and diagnosis of an EM rash. Probably doesn't represent the breadth of human Lyme disease patients. And ceftriaxone for 2 weeks on its own is probably insufficient for the first step of antibiotic treatment. Then there was another study performed by Krepp et al., which was a single-center randomized controlled trial on 55 patients with Lyme disease that had severe fatigue at least 6 months or more after antibiotic therapy. Patients were randomly assigned to receive 28 days of IV ceftriaxone or placebo. And what they found was that additional ceftriaxone therapy in patients with post-treatment Lyme disease with severe fatigue was associated with an improvement in fatigue, but not with cognitive function. So there was another study performed by Dr. Fallon at Columbia, and they looked at repeated IV antibiotic therapy for Lyme encephalopathy, and they had 6 cognitive domains that they assessed. And what they found was that the antibiotic treatment group did much better at week 12. The improvement was generalized and moderate in magnitude, but it wasn't sustained onto week 24. Patients with more severe fatigue, pain, and impaired physical functioning who received antibiotics were improved at week 12, and this was sustained to week 24 for pain and physical functioning. So we're seeing 2 different sort of responses here based on how the treatment was designed and the patient population. So here in this paper, Dr. Fallon's group reappraised the U.S. clinical trials, and what they said was that future treatment guidelines should clarify that efficacy of IV ceftriaxone for post-treatment Lyme fatigue was demonstrated in one randomized clinical trial and supported by a second, but that its use was not recommended primarily due to adverse events stemming from the IV route of treatment. While repeated IV antibiotic therapy can be effective, safer modes of delivery are needed. So here, this is from the Krepp study, and these are all patients versus IgG Western blot positive patients, and then Fallon's paper. And this is a measure of fatigue severity. And you can clearly see that there was improvement for patients who were in the ceftriaxone treatment group compared to the placebo. However, pain was reduced as well in these studies, but cognitive function was not affected as dramatically. So finally, DeLong and colleagues performed this biostatistical review which revealed that retreatment could be beneficial. So the primary outcomes originally reported as statistically insignificant were likely underpowered, and that the positive treatment effects of ceftriaxone are encouraging and consistent with continued infection, a hypothesis deserving additional study. Additional studies of persistent infection in antibiotic treatment are warranted. So those studies have been done in animals. They're very difficult to do in humans, but it's worth considering the idea that combination therapy can help humans. So this is one study which came out of France and Dr. Tulane. And what he did was he showed the progression of 10 patients who had Borrelia, Babesia, Anaplasma, or Bartonella. They all had Lyme disease, or 9 of them had Lyme disease, and several of them had co-infections. They all had neurological limb paralysis and a disability score greater than 4 using the Kurtz scale. He defined remission as a disability score of 0 and complete motor function within 2 years. And they all had positive serological tests for the pathogens in question. They all had disease for over 6 months, including fatigue, pain, and subjective cognitive deficits. And they were treated with cycles of IV ceftriaxone for 30 days. This was variable. And with oral azithromycin, doxycycline, or azithromycin, doxycycline, and rifampin. Rifampin was probably warranted for those patients who had Bartonella. And what he found was that 7 of the 10 patients showed complete remission with a mean of 4 ceftriaxone cycles. 3 showed initial improvement but experienced relapse of symptoms. And 7 of the 9 borreliosis patients obtained complete remission with this combination therapy. So you can see a distinction between monotherapy given over long-term versus combination therapy given over long-term, where the short-term benefits of monotherapy were observed, but they were not sustained. And here you have a combination therapy where remission was achieved in very, very ill patients. Another study, which was recently published, utilized a number of different patients who had pain and neurological and fatigue, the typical post-treatment Lyme disease concerns. They had different combinations of antibiotics shown in this table. The majority of the patients received cefuroxime, rifampicin, and limecycline, and the rating and severity of their symptoms did increase over time, but the number of patients with primary post-treatment Lyme disease symptoms, including pain, neurological manifestations, and fatigue, decreased between visit 1 and visit 2, or treatment. So I had visit 1, treatment 1, and treatment 2. Those were the follow-ups. And so we're seeing that, again, you see improvement using combination therapy, but here we don't know what combination is going to work or be most effective. There are so many different combinations tested here. And the caveat with this study is that it's an observational study. Like the previous one, you cannot determine the efficacy of a specific combination compared to the standard of care because that was not done with these patients. So overall, what we found is that animal studies using mice, dogs, and primates demonstrate the persistence of Borrelia burgdorferi following monotherapy with doxycycline, amoxicillin, ceftriaxone, and tigecycline. Human clinical trials demonstrate that single antibiotic therapy beyond the standard 14 to 28 days can provide some improvement, but it's often not sustained. This is probably consistent with either persistent infection or post-immune or post-infection sequelae. So we need to be able to determine what the cause is. If combination therapy works, then we know that the cause is persistent infection. So combination therapy in mice has demonstrated eradication of the spirochetes, whereas monotherapy has not. Observational studies in humans also show sustained benefit with combination therapy. And I think for those patients, again, who achieve complete remission, the cause is most likely a persistent infection versus an autoimmune or post-infection sequelae. And the final message here is that randomized controlled trials of combination therapy in patients with post-treatment Lyme disease need to be performed. We need to, first of all, establish what combinations are safe and effective and can be tested in a human clinical trial, and then perform those trials so that we can better treat this infection. So with that, I'll conclude, and my references are listed at the end of this presentation. Thank you.